All right, everybody. I know we're getting started just 1 minute early, but welcome to the webinar tonight. And I wanted to just say that I've got to leave tonight at 5:30. And so we're going to get this thing rolling right now. So for those of you that don't know me, I'm Dr. Andy Barlow. I'm in private practice in Tupelo, Mississippi, founder of the Barlow Brain and Body Institute. I've been coaching doctors for more than 12 years. And I'm a graduate of the Carrick Institute of Functional Neurology, and I'm also a graduate of the American Functional Neurology College. The reason I'm stumbling over my words here is because I can't use the word diplomate and fellowship anymore because of some crazy stuff that went on with my state board. So anyway, I'm a Carrick graduate of functional neurology. I can use those words and we'll move on. All right, so this is my Barlow Brain and Body Institute website. You can reach me on barlowbrainandbody.com. When you go on, if you want to, I've got an upcoming seminar in Conroe, Texas on lower extremities for peripheral neuropathy, knee pain, hip, and low back. But it's not just the pain, it's the neurology and the neurological component to pain. And we're going to talk about a little bit about that today. So you can click on there. If you have any questions, you can hit this contact button and we can set up a time to chat. Okay, so let's look at what the definition of pain actually is, because if you ask most people what pain is, they just say, well, I hurt. All right. And it says it's an unpleasant sensory and emotional experience associated with resembling the association with actual or potential tissue damage. Now, this is important because it says something here about an unpleasant sensory and emotional experience. So sensory and emotional, we're going to talk about that today. And then associated with actual or potential tissue damage. Now, if you were to ask most people this, they would probably go, I have no idea what that definition means. I just know that I hurt. So when it says that we can have actual tissue damage, we kind of know what that is. If I twist my ankle playing racquetball, of course it's going to hurt. But what happens when my ankle hurts and there's no associated trauma with it? So we look at that and go, well, there's no tissue injury, but yet your ankle is still hurting. And so you can pick any anatomy, any part of the body and use this. But what about the emotional aspect? So there's an emotional aspect to pain, and the reality of it is it's the emotional aspect of pain is why people do care, not because they're hurting, it's because it's damaging them emotionally in most situations. Because why is it that somebody they'll tell you, well, I've had this problem for 10 years and then and I just decided last month to do something about it. And I'm like, well, that didn't make a lot of sense to a normal, rational person. But this is what we're going to go over tonight, is the unpleasant sensory and the emotional experience associated with and resembling the association with actual or potential tissue damage. So we're going to talk about how you actually may not even have tissue damage, and yet inflammatory cytokines and our diet can actually attack these C fibers, and you don't actually have damage to the tissue, you actually have damage to the receptors. Now understand, and sometimes this is even hard for doctors to grasp this, much less patients, but we don't feel pain in our body. You feel pain in your brain. Your body actually has nociceptors. So you take this nociceptive pain, if you will, you fire it into the brain, because if I lose my left parietal cortex and it completely shuts down, I won't feel anything on the side of the body. You could drop an Advil on it and I won't feel it. So if it's not that the pain in our hand, these are receptors, nociceptors. We're going to talk about how they fire into the brain, and then and how we can actually overcome this. All right, so let's move on. All right, so what we have here is we're going to talk about 3 different types of pain fibers tonight. We're going to talk about A delta. And these A delta fibers basically have to do with, these are mechanical and also cold. So when you hear somebody, these A delta fibers are activating, it's typically because of mechanical, like, I hit my finger with a hammer or something's cold. Now, also with A delta fibers, these are myelinated. So, and myelinated means we're actually able to pinpoint where the pain is. Now with the C fibers are unmyelinated, and these, since they're unmyelinated, you have somebody has shoulder pain. If they're A delta fibers, which are acute, typically if they're firing, they can go, I hurt right there. But if it's C fibers, since it's not myelinated, it's more generalized. They'll kind of rub on it. Now these C fibers, what it's going to impact them are it's mechanical, it's going to be hot or heat, and this is going to be crucial right here. If you're taking notes, I want you to write down chemical, and I want you to circle that, okay? Because these chemical reactants from everything from inflammatory cytokines to inflammation to glycosylated end products to autoimmunity to hypoxia to we'll cover this today, but see, all of these are creating abnormal noxic chemicals that's firing these C fibers, and you're going to see how damaging this actually is to our emotional function, if you will. A crude touch. All right. So what will happen now? We're going to start out with, we're going to look at kind of a 30,000 feet here. So we got A delta C fibers and crude touch, and these are actually going to fire our pain pathways. So a simple diagram here, I'm going to subdivide this out. So we have our dorsal root ganglion, and what we're going to do is we're going to draw our spinal cord out. And in this spinal cord, what I want you to do is kind of draw in like 4 lines right here to make up 5 lamina. So 1, 2, 3, 4, and then 5. And this is called rex lamina. And in the spinal cord, you actually have 10 of these, but we're not going to, since we're talking about pain tonight, we're not going to talk about all 10 of them. We're just concerned about the first 5, actually. So the typical textbook, there's the central canal, and it's going to fire this into lamina 2. It's going to be a little bit more complicated, but right now we're at 30,000 feet, just keeping it simple. All right. Now this system is going to fire over here to what is called our anterolateral system. All right. ALS. Okay. And don't get that confused with amylotropic lateral sclerosis or Lou Gehrig's disease. It's not the same thing. It's just they just use the same letters. So, and from this lamina 2, this is going to decussate or fire across this anterolateral system. And then from here, this system is going to fire up to the ventral posterior lateral nucleus of the thalamus. And from here, it's going to fire into our parietal lobe in area 1, 3, 1, and 2. All right. And then somebody's going to go, ow, I can feel that right there. Ow, I hurt right there, because this neurological system, let's just say I hurt in my shoulder. What's happening is these nociceptive A delta C fibers and crude touch are firing, are being brought to threshold. And now we're sending an electrical and chemical signal through this axon and here through this nerve. And this right here is going to be our axillary nerve. And then it's going to synapse into lamina 2, decussate, and fire up to the parietal lobe. And you're going to go, ow, I hurt right here, or wherever. Okay. So that's the big picture that I want us to take home tonight. But that's the simplicity part of it. Okay. It gets a little bit more complicated than that. So especially when you're dealing with the emotional aspect, but we have to go through all of these other layers to get to the emotional aspect. So let's draw this out. We're going to talk about A delta. All right. So A delta. Now, when we're talking about nerve fibers, just remember there's going to be 3 types. And I'm going to erase this once I write this down. We've got our our A fibers, which are our thickest, fattest, myelinated fibers, our B fibers, and our C. So, I mean, at least in neurology, they made this pretty simple. It's fibers A, B, C. Okay, can't get much easier than that. So we have A alpha, A beta, and today we're going to be talking about A delta. This is not myelinated, but it's the smallest myelinated fiber. Then we get to the next category, and this is B fibers. And the B fibers are going to be our sympathetic chain. So when we go from the intermedial lateral cell column out to the sympathetic chain ganglion, that autonomic system firing into our sympathetic nervous system, this is going to be a B fiber. So here's a little nugget. When people have peripheral neuropathy, they don't just have peripheral neuropathy in their feet or their hands. This B fiber that controls autonomic function is going to be more than likely demyelinating as well because of inflammatory process, dysglycemia, dysautonomia, autoimmune disorder, on and on. So C fibers are actually, people get confused about this because each one of these has to do with the diameter of the fiber, because C fibers are your chronic fibers for pain, but those C fibers are actually the same diameter as your post-ganglionic fibers for your sympathetic nervous system. So just remember, we're talking about the size of the fiber here. All right. Now, so these A delta fibers, and again, this is going to be mechanical and cold. So these are going to fire in, and again, when I say mechanical, somebody drops a sledgehammer on your toe. Now we're going to draw out our spinal cord, and this is where those 5 rect lamina are going to come in right here. All right, we're going to draw 1, 2, 3, 4, 5, and then at this A delta, what's going to happen is this is going to fire into rect lamina number 1 and then number 5. Okay, so the A delta fibers and those 5 lamina have specific areas that they actually go into. And then we're going to come over here. And if you're drawing this out with me, make sure you draw this somewhat anatomically correct. But when these decusate, central canal again, and these decusate, we want to take this to the lateral side right here. Okay. And we're going to go up to the ventral posterior lateral nucleus of the thalamus. And here we are at the frontal lobe on the contralateral side, 3, 1, and 2. All right. Now this A delta, all right, now this is going to come up. We said this pathway is called our anterolateral system. Now here with this A delta, this is going to be the lateral part, the lateral of spinal thalamic tract. Lateral spinal thalamic tract. All right, so spinal thalamic tract. Now this is also in the scientific journal called the NEO. You can't, and that's the thing in neurology. A lot of times you can't just give something one name. You got to give it 3, 4, 5 names just to confuse people. And that's what keeps you going to school so long. All right, and this is called the NEO, considered to be the newest, since it's myelinated, of the pain fibers. And this is going to be the neospinal thalamic tract. So here we can see that it's A delta, lamina 1 and 5, crosses over in the lateral system, and it goes to the ventral posterior lateral nucleus, and then we parietal lobe. Now, when it comes to chronic pain or C fibers, this is where things get very, very interesting. Okay. All right. So this is where your emotional pain is coming in. See, the A delta fiber just goes, oh, I hurt. Oh, my shoulder's killing me. My hip hurt. I twist my ankle playing racquetball. Oh, it hurts. But typically, see, if I twist my ankle, yeah, it's going to hurt. And I know I'm not going to like it. But I know, in the next day or so, getting it on the PMF and laser and all that, that it's going to, the pain's going to abate. Okay. But what happens about pain that's just constant every day, day in and day out, and then you don't know what to do with this? Like I had a lady that started up last week, and she came in and was diagnosed as her doctor as a professional patient. They couldn't find anything wrong with her. She had a lordosis in her neck, lordosis in her back. She was in her early 50s, and she had depression, anxiety, chronic pain like fibromyalgia. So see, what's happening is her C fibers are really, really driving home here. So we've got to get this part down. All right. So C fibers again, these are unmyelinated. They're slower. All right. Again, it's mechanical. It can be mechanical. It can be hot. But the key thing is it can be chemical. This can be neurochemical agents in here that's triggering this nociceptive input. So this is going to fire. This is going to get a little bit complicated. So when you draw this out, we might need to start down here at the bottom of the page. All right. We got our dorsal root ganglion. We're going to fire into the spinal cord. We're going to do our rex lamina again. 1, 2, 3, 4, 5. We got our central canal. And then we got our anterolateral system over here. All right. That's the pathway. I think of it like an interstate. That's the track it takes to get up there. So the chronic fibers, I'm sorry, I keep saying chronic because it's kind of, C fibers are more chronic and have more chronicity to it, but C fibers is going to fire into lamina 2 and then lamina 3. All right. And so this is going to decusate again and take it to the lateral side, because this is part again of in the anterolateral system. This is still the lateral, this is part of the lateral spinal thalamic tract. But this is now named the paleo, not the newest, it's not the oldest, but it's kind of in the middle, all right, of the paleo-spinal thalamic tract. Now here, what's going to be very interesting is when we get into the brainstem. And the brainstem, this is called our reticular activating system. All right, reticular system in the brainstem from the mesencephaline down to the medulla. And it's about, some research says that 85 to 90% of this pathway, of this chronic pain, is going to fire into this reticular system. And we'll go over that in just a second. Let me draw this out first. This is also going to fire into what is called the thalamus. It's called the interlaminar nucleus of the thalamus. Interlaminar nucleus. You may have never heard that term before. That's okay. You may have never heard of these pathways before. That's okay. But just so you know, as a side note, real quick, there are 6 different pathways that fire through these anterolateral systems. All right, we're going to name all of those. All right. So one is your anterolateral system, which we haven't gone over, or the anterior aspect of this pain fiber, which we haven't gone over yet. Lateral system, the anterior system. We've got the spinal tectal. If we don't get time to draw it out, it just means if I'm in pain, if something's hurting me, the tectum is in the back part of your mesencephaline, and you have your superior colliculus, and you go and you look at something. Okay, like if something hits you, you want to look at it. So that's the pain spinal tectal. It fires from the pain fibers into the tectum, which is in the back part of your mesencephaline. Your superior colliculus is there. That's where your eyes are, and you saccade to the pain. All right. So the spinal tectal, we have the spino-reticular, which is this system right here, this reticular activating system. We have the spino-mesencephalic, and one you definitely need to know is the spino-hypothalamus, because this is going to be your autonomic response to pain. Why is it that when you help heal somebody that their blood pressure goes down? Why is it that when you heal somebody, they can sleep at night? Why is it that when you start moving someone toward health, their digestion starts to improve, their cognitive impairment starts to improve? And we're going to cover that. All right. Now, let's go through this. We've got the intermedullary nuclei here in the thalamus. Now, this is interdigitated. I'm going to try to do this here so you can see it. Interdigitated with multiple nuclei in here. All right, hopefully you can see that on the TV screen. All right, so when this pathway fires up, remember 85 to 90% of this is going to fire into the reticular system. The other part is going to fire into the intermedullary nucleus. And what this is going to do is going to fire to the cingulate gyrus. And this is going to be your emotional cingulate gyrus. I'm trying to talk and spell at the same time. Cingulate gyrus. This has to do with the emotional component to pain. Your emotional component to pain. This is the suffering part of it. All right. Now, also in this this laminar nucleus, I'll get it right in a minute. This interlaminar nucleus is also going to fire to what is called the anterior insular cortex. This is in your temporal lobe. And it's called insular, so it's insulated. So if you look at this, you actually have to peel your temporal lobe back, and inside of there and deep in is your insular anterior insular cortex. So, all right, so here is our C fibers over here firing in this slow, dull, achy, boring pain. Okay, and this is going to fire into C lamina 2 and 3. Going to fire over to the anterolateral system. It's still going to stay on the lateral side, or the lateral aspect of the anterolateral system. This is called the paleo-spinal thalamic tract, and it's going to fire up 85 to 90% is going to fire into the reticular system. So what does the reticular system do? One of the things it does is it keeps us awake. All right, it activates norepinephrine, epinephrine. It's going to fire the locus coeruleus. It's going to fire those aspects to keep us awake and actually part of the pain descending inhibitory pathway. This is important because this reticular activating system is also called the ascending reticular activating system. And whenever people are in pain, they have problems falling asleep at night. So that's why I ask patients all the time when they're in pain, do you have problems falling asleep or staying asleep? So, and then you'll hear people go, well, I've got hip pain, so when I roll over at night, if I lay on this hip, man, that thing will wake me up. Well, what they're saying is this dull, achy, boring, type of pain is firing through this anterolateral system. It's hitting my reticular activating system and it's waking me up. Is that reticular activating system has come to threshold, is what I'm saying. If you have a child, you can go in there and scream and yell at a child, and it's like their reticular activating system hasn't come to threshold because they're not waking up. But see, this is a protective mechanism as well, because back when we were hunter-gatherers, if you got a lion gnawing on your leg, you might want to wake up and try to defend yourself. So it has a protective purpose, but it also it can be detrimental to chronic pain. Now, this neurological system is still going to fire to the contralateral parietal lobe in area 3, 1, and 2, and we get this dull, achy type of pain. All right, so anterior cingulate is going to have to do with the emotional component to pain. Your anterior cingulate is going to have the emotional component to pain. And then let's talk about this chemical aspect. So we get hypoxia. Okay, hypoxia is going to cause a chemical reaction here that's going to fire this neurological system. Dysglycemia, which means our blood sugar is dysregulated. That is going to be the inflammatory response from that. This glycosylated end products, inflammatory processes, your insulin surges. All right, you have your let's say gluten. That's my favorite. Okay, gluten sensitivity. That's a chemical that's going to come in here and activate this. Leaky gut syndrome, leaky liver. All right. Then people want to drink sodas and sugar spike. People don't get stimulated. That's going to be a chemical that's, lack of stimulation to keep these systems alive. Processed foods with all the inflammatory processes that happen there. You're activating these chemical processes called inflammatory cytokines. And again, I tell this to patients all the time, leaky gut is going to be a major contributing factor to your chronic pain. Because if you Google how many people have leaky gut, you'll see that 80 to 90% of patients or people in America have leaky gut. And these inflammatory cytokines are going to fire through into this sterile blood system. And they're going to eventually get to this nociceptor, causing this dull, achy type of pain syndrome. And then these people come in and tell you, I've got this dull, achy kind of pain all over my body. I'm depressed. I have anxiety. I can't think clearly. My emotions are crazy. And then, especially with this anterior cingulate gyrus, which is part of your cingulate cortex, people walk in and they look like a grump, like damn, this guy looks like he's about to kill somebody. All right. Well, that's because the anterior cingulate and anterior insular cortex is firing, and they've got this emotional component to pain. All right. So let's move on. I think I beat that dead horse to the ground. Now, another very interesting point here with this. Let me go through crude touch real quick, and then we'll move on. All right, so just so that you know, this part here about $1 and $1 gets you about a bag of chips right here, knowing this information with this crude touch, but you need to know it. All right, so crude touch, this is going to fire in the spinal cord. All right, and this is going to fire into lamina 3, 4, and 5. So lamina 3, 4, and 5. Now, what's going to make this different is this system right here is actually going to fire into your the anterior part right here, the anterior part of the anterolateral system. Remember the other two pathways were your lateral aspect. This is the one that's the anterior aspect. Now this is also called your archeo spinal thalamic tract. And again, this is what it's going to do is it's going to fire to the ventral posterior lateral nucleus and then the contralateral parietal lobe 3, 1, and 2. So this is this is kind of a redundant system, but if you have the anterior lateral system, you need to define what the anterior lateral component is, and that's going to be the crude touch. Okay. Now these systems, what they're going to do, this is one more very important landmark right here. That's going to be extremely important. So you've got these three systems that come up. You got crude touch. You've got C fibers. You've got your A delta fibers. These two are going to be lateral. These two right here are going to be lateral, and then this one is going to be anterior. Okay, so these are going to come up together, and collectively, these are going to be called the anterolateral system. They're going to come together and they're going to converge, and this collectively is going to be called the anterolateral system. Now, what's important here when they converge, I'm just going to draw this as one line now. We're going to fire into the pons, into the pontine area. And there's a nucleus in here that's called the parabrachial nucleus in the pons. Now, this one is very unique because this anterolateral system, when we're dealing with crude touch, C fibers, and A deltas, they're going to fire into the parabrachial nucleus, and this is going to dump right into the amygdala. And the reason is this is going to have our panic, anxiety, fear, and rage. That's what that thing does if it gets out of control. So what happens when people get in pain long enough? Panic, anxiety, fear, and rage. They get pissed off and they'll snap in a second. Okay. So, but the good news is if our orbitofrontal functioning properly, we're going to be able to inhibit this amygdala function. So the key aspect of this that I want you to understand is that when we're firing these C fibers, don't forget that the C fibers have that chemical component where you get any type of inflammatory cytokines that hit this C fiber, and this is going to be part of your lateral spinal thalamic tract that's going to trigger this parabrachial nucleus. This doesn't go to the thalamus at all. It just goes straight into the amygdala. And for this, that's the one where your mom or your dad says, "Don't touch that hot iron. Don't touch that hot iron." And you touch it, and you go, "Damn, I better not touch that again," because see, all that pain jumps into this amygdala, and you get this panic, anxiety, fear, and rage. Like, ugh, I don't want to do that again. All right. And then the last one that we're going to talk about is we want to talk about the anterolateral system. All right. And when I say the anterolateral system, I'm talking about your crude touch, C fibers, and your A delta fibers. So these are going to fire up, okay? And don't forget, they're going to fire into this thing called the reticular activating system, which is going to keep us awake. All right. This is going to fire through our interlaminar nucleus, and it's going to fire to our cingulate gyrus, on shorthand is, and to our insular cortex, anterior insular cortex, and our temporal lobe. This is going to be the emotional aspect of pain. All right, and it's also going to fire to the, it's going to dump right out into the amygdala. This is going to be our panic, anxiety, and fear when it associated with pain. But then this also fires to what is called our hypothalamus. And so we also have a long day. All right, so we have the hypothalamus. So not only do we have an emotional component to pain, not only do we have panic, anxiety, fear, and rage associated with pain, we also have the endocrine function associated with pain. So your hypothalamus. So, somebody stomps on your toe, guess what happens to your heart rate? Goes up. Guess what happens to your breathing? You breathe a little bit harder. Guess what happens to digestion? Shuts down. So when people go, well, why is a chiropractor? Why are they dealing with anything from an endocrine system? If you know what you're doing, you deal with endocrine function every freaking day. Okay. Because if you can decrease someone's anterolateral system, you're going to decrease their emotional output to rage. They're going to sleep at night. They're not going to have this panic, anxiety, and fear. They're seeing that gyrus is going to be under control. Their anterior insular cortex, their amygdala function, and their hypothalamus is going to slow down, and it actually return back to homeostasis. So I'm going to wrap that up with that tonight. I hope you guys learned something. If you have any questions, I do have the floor open for, I'm just going to answer one or two questions, and then I got to head out. So questions, fire away. All you got to do is unmute, hit your mute button, and just ask the question. All right. Well, I appreciate everybody being on here tonight, and also go to barlowbrainandbody.com and get registered for the upcoming Lower Extremities Neural Reconnect in Conroe, Texas. I will be covering this pathway again, but also we need to understand the muscle spindles and Golgi tendon organs aspect to pain, and how the Golgi tendon organs and muscle spindles, how they fire into those lamina 1, 2, 3, 4, and 5, and they actually inhibit pain at the spinal cord level. So look forward to seeing you guys next week, and thank you very much, and have a great evening. Bye-bye.